I was asked to give this debate, and obviously a debate has to be entertaining and it has to be controversial, otherwise it's no debate, otherwise you can have coffee. So I put a little question mark behind as a bit of a compromise to my talk. So let's see where we get at. So my first slide is this one. There's two parts of it. On the left side, you see the first tragic record of heart transplantation, which is a Time Life magazine cover, which I found in Portobello Road Market 20 years ago, bought it for £1. It shows a group of patients who had their heart transplant in 1968 by Denton Cooley. At the time when this picture was taken, all these gentlemen were still alive. When this was published, they were all dead. Because in those days, nobody knew anything about heart transplants. We didn't know about which patient to take. Immunosuppression was poor, everything was poor, we just did it. So, and it worked. As you can see, patients lived. So on the right-hand side, you can see the other tragic record of heart transplantation, which brings you right in the 21st century, showing you the situation in the UK. As I said in my last talk, down from 350 transplants in 1995, down to below 100 in 2011. So that's reality. So we're serving 100 patients per 60 million with donor hearts. That is the tragic reality in the UK at this point in time. Again, this is just another illustration of this. This same, John showed this slide. So again, I'll come back to this sort of not so fabulous result, because it is not so fabulous. If you look at a surgical procedure in the 21st century, I'm not talking about the infancy of cardiac surgery, when everybody used to die at a rate of 10% at least. We're dealing today with cardiac surgical procedures, mortality risk in the range of 1 to 2%. This is our range, what we normally do, every one of us, every day. This procedure carries an immediate risk, the first day, of 20 to 25%, slightly less in the UK because our results are not as good as internationally, even more less in Germany, which is even worse than the UK. So this is the immediate risk you have to quote to your patient when he asks you actually, what's my risk of dying? And this doesn't relate to patients having a VAD before. This is a straight box standard heart transplant, has an immediate risk of 20 to 25% of dying. And this hasn't changed. Slightly, not really a lot. And if you look into the details, then and you've seen that in my previous talk, if you look up more risky patients, it actually shows you that if you split it up into smokers and drinkers and patients with vascular disease and what have you, and this is our general population, you get even worse results. And nothing of what you heard before is in fact true, because the vast majority don't get to 10 years of those patients. Let me just take that further. There's more problems actually with it, which hasn't been mentioned before. If you look at this slide, it very easily summarizes the price patients have to pay when they get transplanted. At 5 years, 90% have high blood pressure. A significant number, i.e. 30%, have renal dysfunction, high lipids, diabetes. About 40% at 10 years suffer from diabetes. And why is this? Because they all take immunosuppression. And more than that, a lot of these guys have malignancies. This is not data I made up. These are published data. And at 10 years, you have 70% of patients having malignancies. And this is because they all take these cocktails of toxic drugs. They have to take it, because if they don't take them, they die. If they take too many, they die of infection. If they take not enough, they die of rejection. So this is the honest truth about it. And you can see all these toxic, none of these drugs is non-toxic. They're all toxic. And it's not just that. If you're a female, you have grown facial hair. You look terrible. Or you have a Cushing weight face. So that's a small price to pay, I agree. But anyway, it's the real truth. Then obviously the other problem is, if you aim for more donors, and we did this very successfully. I was one of the first ones in '87 published a paper on extended donor criteria. So we went up to the age of 60-year-old donors, and we were quite proud that most of them actually worked well. But if you look at the international database on donor age, and you look at the mortality risk, This is 1 here, so if you get a young donor, it's absolutely fine. But if you go up to 60, you double the risk of dying, in early dying. So that's what we all do, including Papworth. That's what they do. So compare this with most recent, well actually not most recent, but a couple of years old VAD data, and you can see a fantastically low early mortality. So this is 21st century mortality. That's what we like to quote our patients. Low risk of dying early, because they are in trouble. So they want to know, how can I get through safely? And if you look into the internet database I've shown you, this is the much more larger cohort than the previous small number of center study. You can have a reliable survival of 80% at 1 year, 70% at 2 years, and 60% at 3 years, which is quite remarkable for a procedure which has been established maybe 5-6 years ago, compared to heart transplantation, which has been started being implemented in the 80s. And obviously the same, pretty much the same for destination therapy, so for high risk patient group as well, not much inferior, and even above the age of 70, you get pretty good results. I'm not sure whether patients at the age of 70 get transplanted in Papworth, I'm not sure. So, yes, it's a nice procedure, but it is not happening. So that's the bottom line. And looking at the UK, so what's the UK situation like? So you get 6 centres, you get 100 to 120 procedures. So that's roughly about 17 to 20 per centre. I just made an equal. John is obviously the most busy one in the country, so I acknowledge that. So each centre has 5 surgeons at least. That's by law because of the European working directives. You have to have a compliant rota, which requires 5 surgeons to be in the VAD team, in the transplant team available. So if you break this up, so this surgeon, Leslie Hamilton, Joel Dunning, Jenkins, all these guys, they do maximum, at best, 3 to 4 procedures a year, at best, most of them less. You get 12 anaesthetists, at least in our department, you get 12 anaesthetists. So if you break this number up, so it's 1.4 heart transplants per anaesthetist per year. And of course that explains the high early mortality between 20 and 25% at Papworth. Of course. And that's why a number of centres have been investigated because of poor outcomes in the past. That's quite rightly so. You can't change that if you do procedures so infrequently. And this is again supported by the international database, which clearly shows you a relation between number of procedures and outcomes. If you do many, your results get better. If you do few, like all of us do in the UK, including Papworth, your results get worse. So the other issue which we have to always think about, this is always brushed under the carpet by all these discussions, the huge expenditure on resources. So for each single heart transplant, you get an on-call team 24/7. You got surgeons, anaesthetists, coordinators, ITU nurses, theatre staff, tissue typing, NHSBT infrastructure, air transplant, retrieval team, ground transport. About 15 to 20 people are actively involved in each of those 100 procedures per 60 million people. Obviously, most of the time, procedures at night. There's a lot of unsuccessful calls, transports across the country. We get patients over from Belfast flying in the middle of the night, in the middle of the winter, and the patient will be sent home the next morning with the same flight. And obviously, if finally the patient gets a transplant, he'll be looked after in his outpatient clinic, highly specialized post-transplant cardiologists who see the patient until they die in 15 years, every single time, to discuss their cyclosporin level with this particular patient. And for that reason, he has to travel from Belfast to Newcastle to get this sorted out. So all these resources for 100 to 120 procedures across the country. Then there is the allocation. If you were the average man on the street, you have no idea how hearts are allocated to patients on the waiting list. You don't know anything. And this is kept secretly amongst those few who actually do this. So the allocation system is not audited by any non-transplant person. by any non-involved person. High urgency listing is not ordered independently as well. There is still regional allocation system, which obviously leads to inequality. It has been abundant in other countries, but not in the UK. So you might get a better chance of getting transplanted in Newcastle as compared to Papua or Brompton or Hatfield. So then the decision who gets transplanted in the middle of the night is made by a single surgeon who is in bed, woken up at 2 o'clock in the morning, picks up the phone and says, oh yeah, I'm going for Mr. Smith. There's no MDT, there's no discussion about it, nothing. It's an individual surgeon in the middle of the night makes the decision who gets the organ. What would you say if this message gets out on the street and discussed in the papers tomorrow? Nobody knows about it. And obviously the numbers and the investigations lead to risk-averse behavior, which we all know. If I'm tired in the middle of the night, why would I pick a high-risk patient? Why? I take the easy one. Because I get up in the morning and I'm happy. It's fine. It's no problem. So this is reality. So how about the general effect on heart failure? This attitude, all these information, what sort of impact does this have on the general situation of patients with advanced heart failure? There's restricted referral of transplant-eligible patients due to a lack of assessment infrastructure. So the bottleneck is kept out of the hospital. So keep the patient away from us. We don't want you. Stay away. Because there are some cynical comments such as, oh, we can't transplant you anyway, so don't come. Lack of experienced heart failure cardiologists. There's only very few fully trained heart failure cardiologists in this country. There are some post-transplant cardiologists, yes, but very few full-size heart failure cardiologists. And there's huge pressure from funding organizations on patient selection for MCSD, so don't do it because it's too expensive. If you do it, you get a couple of letters and nasty phone calls. No MCS for non-transplant patients. No acute MCS, which we heard this morning, outside of the 6 designated centers. And there's complete arbitrary guidelines for selection, not compliant with international experience and scientific publication and work. Why? Why is all of this happening? Historical. This is a historic system. And there has been no structural changes in the last 20 years. There is no audit ever on the usage of the resources of all our transplant centers. There's no independent assessment of distribution of organs. There's no accurate cost-benefit analysis. There is no competition, and there's only a few involved. This is why we heard the talk we heard before. This is exactly why. So now let's go to the LVAD. Let's go to something positive. Something forward-looking. Give me 2 more minutes, David.
Does that mean I get 2 more?
You can have as many as you want. So significantly better early outcomes, off the shelf, during the daytime, nobody's tired, controlled, well-planned, LVAD always works, no graft failure, can be replaced anytime. Overall, less expensive, low level of infrastructure in future. You can have minimal invasive techniques, so small incision, low morbidity, transcutaneous models will be available on the shelf pretty soon, and there will be advances in technology which you don't have in transplantation. It's an old procedure running out. This is just to show you a system which will avoid the dry line. So what we should aim at now, having this technology, is we should have a structured cooperation between centers for general cardiac surgery and designated long-term centers, so a network. So allowing for better access. All cardiac centers should have access to some sort of basic equipment, all of them. This should allow for a broader application of life-saving technology, and obviously this would lead to more cost effectiveness. And all of this would lead to a higher number of lives saved in general. And this again is a fairly clever slide I borrowed from Jim Kirkland, showing the typical 2-year mortality, which everyone has, including Papua. This is like a straight line. And if you take a regular patient on an LVAD, you can implant up to 70 years until you cross the mortality figure of an average transplant patient. This leads to this wonderful concept which we're all using today, where still transplantation has a role. Obviously, I'll come to that in a minute, obviously, but it's not happening. It's a wonderful procedure, but not happening. So I have a few conclusions for you. Heart transplantation, very successful therapy in the past. Drug-associated toxic side effects have a significant impact on long-term morbidity. Historical problems associated with heart transplantation concerning organ allocation, clinical experience, and clinical habits leading to unchanged early outcomes. Reorganization of centers and better usage of resources is absolutely necessary. A new generation of LVADs show impressive survival, etc., etc., etc. So basically, what I think is the future, maybe also as an interim, the majority of patients with advanced heart failure will receive VADs in the future, and heart transplantation will be mainly for those who are not suitable for VADs, because there are some, John mentioned a few, and those who have VAD-associated complications. So I think VAD therapy should be the new gold standard, and this is something of the past, and this is something of the future. Thank you very much.
I'm easily convinced. Once again, I'm convinced. I think that heart transplantation seems to be evil. So why don't you come up here? I think we should have a couple of questions in the interest of, and then I would like in the end maybe we should have a vote.
He knows he's lost already. It's all right. Do you want some questions first?
Oh, okay. We have a 1 minute rebuttal by each. Okay. I give you exactly 1 minute, one rebuttal by you, one rebuttal, and then we'll have a short question session, and here you go.
Okay, so anyone who comes to Brighton knows the history of party political broadcast that's happened here. And of course, Stefan clearly is schizophrenic since he's wearing both blue and yellow, but that's probably appropriate, isn't it? I'm really grateful to you, Stefan, for simply continuing to support the motion that I proposed, that actually heart transplantation is still the gold standard for treatment of advanced heart failure. You spent a lot of time showing the shortcomings in heart transplantation, and I agree that those issues need addressing. You spent quite a long time explaining why we should be developing all sorts of new things associated with the ventricular assist device therapy and mechanical circulatory support, but you entirely failed to show that at this stage it is superior to heart transplantation for patients with advanced heart failure. I think you failed in your mission here today. You showed us an extensive team involved in transplantation. The only person not required in the VAD team is the tissue typist, but all the other support issues are still there. I think transplantation still has a future, and it will always remain the last vestige for the surgeon when mechanical devices fail. Thank you.
Stefan? 1 minute?
Well, okay. Yeah, John, I still like you. I mean, it's so evident. I mean, you know, it's like, I remember, it reminds me of Norman Shumway's quote when he was asked, what do you think about xenotransplantation? And he said, it's wonderful. It's wonderful because it's never happening. So I think you're delusional. I think you're entirely delusional, and it illustrates your age as well, because you've been growing up in a time when the John Warworks they kept brainwashing you, and they kind of indoctrinated you about staying away from the evil. Because I remember, and this is a serious point, Papworth tried to do a destination trial, which completely collapsed after 2 or 3 cases. Or 4 cases, I remember. Mr. Schofield, Dr. Schofield was the physician, and Mr. Warwork at the time was the surgeon, and they completely failed. At the time when the rematch was taking off and the whole world was listening to the American centers. So I can understand where you're coming from. This is like your upbringing. So, and I think, yeah, I think it's so evident that you know, VADs are the future, and this is something of the past.
Thank you very much. One question from the audience at least. If some of the younger generation, not the dinosaurs, I've been called the dinosaur, so I may. So then we'll have. Well, come.
Stefan, can we afford mechanical support for the thousands of patients who you say will need?
I think we will, because we're wasting so much money at the moment for this whole transplant infrastructure, which we completely can clamp down in the future. I think we can distribute it, and we can make it very cheap. The other thing is, the companies obviously, they have to sort of get some some money back from their investment in developing it. So I presume when we use more, prices will come down. It's the same as for heart valves, so I have no doubt. And in the future, the VADs will be low maintenance in terms of their follow-up care.
Just like an aspirin, £1.50. Martin.
While listening to you, the idea, why not looking at kidney failure? Because this is the other system where we have long-term replacement therapy. So maybe this is a debate that has been happening before for kidney failure in between dialysis and kidney transplantation. And still, I do not know what is the gold standard for kidney failure. Is it dialysis or transplantation?
Depends on who you talk to.
It depends on who you talk to.
I think we should have a vote before we conclude this. So who now would agree that heart transplantation remains today and maybe for the future will remain to be the gold?
That's
Motion
today.
is today
Motion
is
is
today
today.
in 2013 is the gold standard. Who would
Hands for heart transplantation.
heart transplantation?
Are we excluding industry from this?
Of course not. Then who would think that the ventricular assist devices are the gold standard for treatment?
It's close.
It's 13 versus 8.
So heart
I think,
transplantation.
no, I was
That's good.
Yeah.
Thank you very much. Before we
Hold on a moment, please.
Before we conclude, because there's a tradition of the SCTS to honor the speakers who have been invited and took the time to travel here and present. And so this is Professor Martin Schueler from Leipzig, who has been here today, and we will give him this wonderful paperweight, which is actually has your name on it, so you cannot give it to anybody. The next time when I visit you in Germany, I would of course expect you to have some exposed place on your desk. Thank you very much for coming.